I appreciate being here. Today I'm going to talk to you about two subjects. The first will be MACRA and the second will be RUC. And that's why I'm standing here. So I'm afraid you'll throw those catch box things at me when I talk about some of these things that's going to very much disrupt your practice going forward. I'm really appreciative of being here because my favorite partner of all times is your president, and Ben asked me to give a talk here. Ben, thank you very much. Also, my brother was Jimmy Waits. Jimmy was president of Southern Medical, and then my sister-in-law was president of the Alliance, and Ben's wife was president of the Alliance. So a lot of contact with Southern Medical in that regard. I actually went to several of your meetings, including one at Nashville when Jimmy was inducted into being president. So this is a slide here of what the government plans to do. We're going to make a better, a smarter, a healthier healthcare system. And just to prove I am Jimmy Waits' brother, here he is when he graduated high school and when I graduated kindergarten. Actually, we didn't have kindergarten, but more or less what I was doing there. So better, smarter, healthier, that's what the federal government says we're going to have. That's sort of what we talk about with the triple aim of having lower cost, better health, better outcomes that Don Berwick, when he was administrator of CMS, introduced. And that's what we in the American College of Cardiology, for example, this is our strategic plan, and that's what we're aiming for, is that triple aim. So I have a video for you here. This will last just less than 3 minutes, and this will give you an idea of what the federal government feels like we're doing getting towards this triple aim.
Important possession, your health. And rightly so. In America, we're lucky. We have some of the best doctors in the world. But right now, our healthcare system often makes it difficult for them to practice medicine the way they think is best. In many hospitals and clinics, if your doctor wants to take the time to sit down with you and learn more about your health, or help you understand your care, she doesn't get paid. If she wants to try a personalized approach that isn't on a predetermined list of services, she doesn't get paid. And there's often no way to pay her for doing the work that we know keeps people healthier, like preventive care and educating patients to live healthier lives. Instead, our system pays for tests, treatments, and procedures. Saw 30 patients in a day? Check. Did a biopsy? Check. Read an x-ray? Check. Not surprisingly, this has led to more services and higher costs, and it often leaves doctors and patients unsatisfied. Over the years, different programs have tried to make things better, but change was sporadic and fragmented. We have made progress, like helping the vast majority of doctors adopt electronic health records. But some of the requirements were too complicated or complex, and the fundamental goals got lost. Many doctors were frustrated, and some couldn't or didn't want to take part. To help fix this, Congress recently passed a bipartisan bill, supported by doctors and medical groups, to change how we pay for care. This new effort is called the Medicare Quality Payment Program. Instead of payments that encourage assembly line style of care, this program helps doctors focus on quality and the one thing that matters most, whether patients are getting healthier. Here's how. First, it replaces our patchwork collection of incentive and penalty programs with a single one. And though we will still pay for services, every doctor will have the opportunity to be paid more for better care and investments that support patients, like creating a helpline or having nurses follow up at home. And for doctors who want to go further, there's a second option that's even more flexible. They can decide to be part of new organizations that get paid primarily for keeping people healthy. For example, they could be part of a health home, where a team of doctors work together to meet a patient's needs. On this track, doctors can help patients understand prevention and wellness. They can try innovative approaches like telehealth or nutrition classes, and they can focus on keeping people healthy. We are working with doctors, insurers, health organizations, and patients to make sure we find the path that works, one that's simple to use, pays for better care, and keeps important programs like Medicare sustainable. These kind of smarter payments give doctors more freedom to practice medicine the best way they know how. They take people off the assembly line and put them in the center of their care, and they are key to making our system work better for everyone. To find out more about other efforts like this, go to hhs.gov/delivery system reform. Better, smarter, healthier. This is the future of healthcare in America.
So that's the government's view of where we're going with the new law that's coming out. I think you may have a very different view of it, and what I would say is we're about to be hit by the MACRA truck. I am within the ACC part of the MACRA task force, so I'm a bit immersed into this, but I can't say with my Baptist background that immersion has saved me in any way. I'm fairly agnostic on whether MACRA is going to be the best thing we've ever had or absolutely the worst thing we've ever had. From the video there, it kind of looks like it can potentially be the best thing we've ever had. I can tell you definitively that it is very complex. So I would like to know, how many in the audience know nothing or very little about MACRA? That's what we see all over the country right now, Dr. Kumar. How many know a fairly good bit about it? I'm pleased to know that Dr. Kumar knows a fairly good bit about it. Yes, thank you. So all of you speak up who do know a lot about it. I know some of the facts, but there's a lot of great unknown about what's coming up. So there are a lot of acronyms and not initialisms, and one of the initialisms is DSTM, and what does that stand for? Don't shoot the messenger. That's me, okay? So I am here to tell you what we're seeing. So here's our first catch box thing, or we're not doing a polling system. Based on the MACRA law, what percentage of Medicare total payment will be, and I added sort of standard fee for service in 2025? Do you think it's 25%, 50%, 75%, or 90%? How many of you think it's 25%, number one? How many do you think it's that? Okay, a few of you think it's that. How about 50%? 75%? 90%? Okay, does anybody want to speak out the answer with the catch box? Well, the answer is going to show up a little bit later on, but I'm going to tell you now it's 25%. Only 25% of what you do will be standard fee for service come 2025. All the rest of it will be through the alternative payment models, et cetera. So MACRA, in brief, does two things. It replaces the SGR, and it goes to a two-payment pathway. And the two-payment pathway is the MIPS pathway, and we're going to do a lot of talking about that, and the alternative payment pathway, or the APMs, more acronyms and initialisms. Were we as doctors pushing Congress to pass the MACRA law? What's the story? If anybody here knows the answer to that and knows why we got it, I welcome you to stand up and talk about it, or I'll do it myself. Dr. Kumar?
This basically occurred at the AMA. There was a big push, really, to get rid of SGR. However, Congress, with its funding of how Medicare and Medicare is, which is a zero-sum game, wanted to ensure that if we move away from fee-for-service, that the cost would not go up, quality will get better, and all the aims of triple aim will be achieved. So it was pretty much a decision and a discussion related to how do we get this going in a zero-sum game, and to get rid of SGR, MACRA was the best way to make it happen. However, as with many laws, many issues related to healthcare policy, the initial law related to MACRA, there was a lot of concerns with it from a lot of physician groups. They took it back to Congress, and most recently they came back with the finalization of that, and I think you're going to talk about that.
Right. Yeah. Thank you. Excellent. We didn't prepare that, and that was wonderful. So creation of MACRA, as Dr. Kumar just prepared you for on that, first of all, we had the SGR, the Sustainable Growth Rate Formula, and that was a great failure. It was introduced to try to keep the cost of health care kind of matched up to GDP, but it simply didn't work, and right from the first year forward, doctors built up debt. It was like they were paying us, and they were paying us too much, so we owed them the money back. So every medical society in the country, I know Mississippi State Medical Association just actively fought this for a number of years, and finally SGR was repealed. And so that was repealed in a very bipartisan way. We had a big love fest between John Boehner and Nancy Pelosi during that time. Let's see, where's my light? There it is. And it was passed with a large majority of both the House and the Senate to get rid of SGR, and they replaced it with MACRA. And the MACRA is the Medicare Access and Child Reauthorization Act. There you go, thank you. And again, it got rid of that, and we now have quality-based system going forward. And now, interestingly, it combines what we're already doing, the PQRS system, the value-based modifier, and the EHR, into one program as we go forward. Wanted to say to you, I have lots of words on some of these slides, but that's mainly because Mandy's going to make a PDF available to you afterwards so you can potentially relook at some of this and learn more about it than I'll be able to tell you as we talk today. So it did also do some minor things in a way. Got rid of the two midnight rule for a little while. It's now been brought back again. Again, the CHIP program was authorized, gave some money to the graduate medical education program for a while. Very nicely is trying to help us be interoperable with our electronic health records. Now, something I think was real important and wasn't given much information at the time, it does, in a legal way, make it so that these new programs are not the standard of duty of care in medical liability cases. So I think that was important. It changes the landscape. It said that this is the most dramatic change we will have with Medicare since Medicare was introduced. It is basically value instead of volume. That's what it's pushing towards and trying to bend the cost curve and save some money. There will be annual payment updates with this. Initially, it's a 0.5% annual payment update to the Medicare payment, and that's for these number of years here. Then for these years, there will be zero update, and then after 2025, starting in 2026, this is where I was talking about in that question, 75% of all participants will be doing alternative payment model, and only 25% will be doing what I call sort of fee for service, because we already are doing the value-based purchasing, the PQRS and those kind of things. So again, this is where we are now. This is MIPS presently. This is the merit-based incentive payment system. We already have these three things right here, and then clinical practice improvement has been added by MACRA. So presently you're doing PQRS, presently you're doing meaningful use, which is mostly the electronic health records, and presently you're having to do the value modifier. What we see in the world of cardiology, and I think this would probably be fairly typical in most of our societies, is we were doing fairly good in the last couple of years with PQRS. We were able to see that of the eligible cardiologists, most of them were participating in PQRS. So our thinking is that in the first few years anyway of MACRA that we'll be pretty good, because we're sort of used to the process other than the one thing added. This is very wordy, but this is to kind of give you an idea of the percentages. So quality measures, and I'm going to explain that more in some other slides, will be a fairly large part of the MIPS. Resource use, or how much you're costing the government, will be a smaller portion right here. And in fact, with the new changes that Dr. Kumar mentioned, that's going away for at least a year or two. The new item is the clinical practice improvement activities, and there are quite a number of those that you can choose from, fairly large percentage. And then 25% will be advancing care information, which will be your computer work, your electronic health record, trying to make those interoperable, still doing your electronic prescriptions and so forth. So some of that you are already doing. This gives you a little bit more granularity on that, as well as giving you some idea of what happens. You're going to be getting points for these. So in the quality area, clinicians choose 6 measures to report to CMS, and these are chosen by you that best reflect your practice. One of these measures must be an outcome measure of a high quality thing, and one must be a cross-cutting. Well, actually that cross-cutting has been cut out by the latest version of this. And this is going to be 50% of your payment. Then the advancing care information, again, the computers, that's going to be 25% of your payment. The clinical practice improvement activities, and there's several categories of these, and you're going to be choosing from as many as 90 activities on it, will be 15%. And at least initially, cost will be 0%, but it'll be phased in over a few years. stop me at any point if you have questions, but we will have questions at the end of this. And my thought is we'll have as many questions on MACRA as you'll like, and then we'll gauge the RUC talk to how much time is left. Okay. So this is an idea of how many of us will be under the MIPS category rather than the alternative payment model category. And it appears that most of us, all this blue area here, will be subject to MIPS, merit-based. And this is not in alternative payment model. A few will be in non-advanced alternative payment models. For example, our clinic, Ben in my clinic, the Hattiesburg Clinic, has an ACO, but it's not called an advanced ACO, so we will not be qualified for that category. A few will be a mixture of that, and then a very few people at the beginning point will be in the alternative payment models. And again, I just bring in the paper to you. I'm just giving you the message. This guy is a messenger that I think a lot of people would like to shoot right now, to give you a little thought. You know who that is, don't you, Ben? That's Julian Assange and all of his WikiLeaks. So he's quite a messenger. So lots of words here, and this is to give you just a few points. This is your quality reporting basics. So look how complex this all is. You're sure going to have some extra staff to be able to do all of this stuff. So the weighting of MIPS, 60% of your total MIPS score will be in 2019, phases down to 30% in 2022. The measures, you'll be having 200 or so available, and you have to pick 6 of them. It used to be you had to do the cross-cutting, but again, in the goodness of CMS, they cut that part out. Your scoring will be this type thing, and at the end of the year, you will have one number. You will have a number, and that will be matched across the country with everyone else. There is the option of some bonus points in this if you do certain things with your electronic health record, especially, that give you these extra points. Here are the basics of resource use. Well, this is all going to be claims data. You'll have very little yourself to do about it other than trying to do a good job in controlling cost and so forth as you do it, but that will all be through claims data. CMS will calculate administratively being claims over a full year, and you'll get paid 1 year based on what you've done the previous year. The advancing care basics, this will be 25%. You fulfill your required measures for a minimum of 90 days. This is a nice relief that we got in the very recent thing. It was going to, before this, be continuously you had to add all this information, but by the latest, now you'll just have to do that for basically 3 months of the year. Then your basics on the CPIA, Clinical Practice Improvement Activities. This is 15% of your total score, 90-day reporting period. In each of your specialties, you will have around 90 activities you can look at and choose from 8 of them. Again, here's the point category. And for non-patient facing specialties and small rural practices, you'll need fewer points. Now, thank goodness for this small rural practices part, because until the most recent change, the prediction by CMS was that practices 10 or fewer was going to fail. They were not going to be able to do this. So they're starting to make some allowances for that through pressure from multiple societies that have commented on their initial rule. Now, the non-patient facing, that's for any of you, if you happen to, like in cardiology, to be imaging, where you do most of your time reading echoes or nuclears or whatever, and don't see that many patients, then you have a special category. And each one of your specialties probably has members that are like that. Now, just some ideas of what the categories of that CPIA, which is such a big percentage. It will be, for example, expanded patient practice, like having more access. Under population management, starting an anticoagulation systematic program within your practice. Care coordination, participating in some kind of transformative thing. Beneficiary engagement, this is where you're going to do your surveys and so forth, and that will count. For some places, there's already this Million Hearts campaign that started several years ago, but now has been incorporated into MACRA, and CMMI, the Innovation Center, has put a lot of money into this. Currently, there are many practices across the country that are in the intervention part of this. There are other practices that are in just the data gathering part of it. And what they're basically going to see is in the intervention, if a practice, for example, really tries to emphasize risk reduction in the world of heart disease, then there's going to be a period where the study completes, and there will be a study, and they'll see if this really works. But they're going to be paying practices a few dollars per patient to do this risk reduction model. Just some other things, for example, patient safety, consult, you have psychiatrists available within your practice, and the integrated behavior model. I know in Mississippi this is a fairly big thing, trying to co-locate mental health services in your clinical care settings. So here are how some of the adjustments are going to be happening to you. For the MIPS category alone right at the moment, there's going to be, of course, a neutral area where you're at the threshold. That one number you have is at the threshold. You're in the median mean of all that. If you're in the negative, then initially, starting data gathering next year, 2017, collating all the data in 2019, you may have a 4% drop in your payments from Medicare. And the next year it's more, and then the max at this time in 2022 is a 9% penalty, basically, if you're negative in the MIPS category. Most everybody will be in the middle category. For those that are in the positive category, and depending how many are in this one, they may get up to 3 times the amount in the positive category. So automatically you've got an 18% spread between this group, and there's a possibility of that being even more. So a lot of winners, a few winners and a lot of losers potentially in that. And all of this, I like this word, penalties and incentives will be proportionately distributed. And you wonder who in the world is going to do the proportions and how the proportions are going to be done. I'm sorry?
Statisticians.
Yeah, statisticians somewhere is going to be doing that. So that's MIPS. We're going to move now into the other one, which is going to be 75% in the future, and that's the alternative payment model. So CMS criteria for an advanced alternative payment model is, first of all, you do have to have certified electronic health record. The payment part of it is more or less comparable to the MIPS, but there has to be, quotes, nominal risk. And nobody right now knows what nominal means. That has not been defined. You can have the medical home model for this. Based on revenue and patient threshold with differential awards is how you become whether you're a qualified participant or a partially qualified participant. So how much you are making from Medicare and how many patients you have in Medicare will help determine that. Now going forward, if you are in the alternative payment model, then every year automatically you're going to get a slight uptick in your payment from Medicare. If you're a MIPS only, then you're going to have also an uptick, but a third as much as the alternative payment model. So they're absolutely trying to move us all towards alternative payment models. So the timing on the alternative payment model from 19 to 2020, about 25%. At this time frame, they're looking for it to be at least 50%, but again, starting in 23, they're looking for that to be 75% of the total Medicare revenue. Here are some ideas of what advanced alternative payment models are. Again, it requires certified electronic health records. You have to have some risk involved. So these are some that are already out there. You might know the dialysis folks already have a model. There is a primary care model that's just been introduced called Primary Care Plus. Some people are already doing Medicare shared savings programs. So again, this is what the Hattiesburg Clinic where Ben and I have worked doing, but we're track 1, which has no risk involved. It's just a sharing program with no risk, and so that doesn't qualify as advanced. But if you have risk, and depending on how much you have, you're either track 2 or track 3. There's an oncology thing, and then this one is really big for cardiology. and for cardiac surgeons, starting fairly soon and based on metropolitan statistical areas, I think it's 98 hospitals are going to be designated to have to do this model. And at that point, every heart attack will be entered into a bundle. We're hoping that they will allow us to do just STEMI heart attacks, but it may be all heart attacks. So everybody with a positive troponin that's called a non-STEMI or whatever is going to be in this. And it's going to be hospital control, bundled payments, all Medicare B payments. Part B will be in kind of the hospital coffers until it's divided up in whatever way groups work out for it to be divided at the end of a year or whatever period of time it might be. So that is bundled payment for myocardial infarction as well as bundled payment for coronary bypass. Currently, there's a bundled payment for valve disease that a lot of centers are already doing with a no-risk model for that currently. So big picture here, if you participate in advanced alternative payment, if you receive 25% of your Medicare payments or see 20% of your Medicare patients through this in 2017, you'll be getting a 5% incentive payment. If you now look at macro payment adjustments, low performance, benchmark, high performance, and you're in the MIPS, during this time, 15 through 18, we're going to be doing what we're already doing. Again, in 19, it's going to be starting this 4%, building up to a 9% differential between the high and the lows. But the alternative payment, you'll be getting the 5% every year during that time frame. This is just another picture summarizing that for you. And I think over here, this is important in that, again, there's a differential even way out here between the two categories. The potential for higher MIPS bonuses based on budget neutrality factors and exceptional performance is it could be even more than an 18% differential between the top and the bottom. This is what, for example, Hattiesburg Clinic is already doing to try to get involved with this. I've been quite impressed with what they're doing. Dr. Batson, Ben, is the one that's really running this program. Starting back here in June, started an in the building hypertension quality improvement program, already doing various surveys. Blue Cross is working with them on a diabetes initiative. United Healthcare is already starting an accountable care organization. We've hired a psychiatrist now to be part of depression quality improvement initiative. The CAPS is more about surveys, and then this is the Million Heart campaign I was telling you about. And then January 17, the data for MACRA is starting to be collected. Hey, this is getting kind of boring, I know, so let's move on and say the final rule came out. And the initial rule had 2,000 pages, received 400 plus public comments. I know the ACC was exceedingly active in giving comments to that. And now with the final rule, there's still, even though it's final, there's still another comment period for the next 60 days. And so we'll get the final part of the final rule, 60 days, well, this came out on October the 14th. So this actually had some nice little perks that came with this. A gentleman named Andy Slavit, who is a physician, is the acting commissioner at CMS. And to hear him talk, he's really trying to do what he can for physicians. Pardon?
So he's trying to make it work.
He's trying his best to make what he was given, trying to make it work. So as of now, there is going to be some testing. You can submit data in this time to avoid a negative penalty. You can participate in part of the calendar year or the whole calendar year, or you can participate in an alternative payment model. So there's some leeway in this next year that was not there before the final rule came out. But there are some penalties. If you don't participate, you may get a negative 4%. If you submit something, you're at neutral. If you submit a partial year, then you may earn a small positive payment adjustment. If you do everything, then you have a chance for a pretty good bonus in the first year of the MIPS program. So there is small practice assistance that was not there until this final rule came out. Now they have finally listened to people and said, well, maybe you can report as a virtual group, so all the 1 and 2 and up to 10 person practices have the option of joining with other similar groups to be a virtual group for the MIPS and the alternative payment thing. And so individuals are groups of less than 10 there. And this is just to show you that same thing, but you'll notice that the cost or the resource use is taken out, and that's going to be started up again more or less in 2018. So it's going to be phased in. There are some more advanced alternative payment models that are in here. Interestingly, this track that a lot of clinics are in right now, the track 1, is now anticipated to be an advanced, which is really good, but it has to add some risk, even if it's a nominal amount. Now, that's sort of it for my talk. I will say to you that we have multiple places you can get information. This will be on the PDF that you can pull up later on. The American College of Cardiology is certainly trying hard to make things available through this website right here. All right, let's move to the RUC and some question time after that about the RUC, and we can have more questions maybe then about MACRA. Okay, perfect. So again, a question. How many of you are very aware of the RUC and its actions? That's what I thought. Until I became a part of the advisory thing for the RUC, I knew absolutely nothing about it. So the RUC is the Relative Value System Update Committee. It's an independent group of volunteer physicians that go to this. It's kind of giving us our First Amendment right to be able to petition the federal government about how they pay us. It's comprised of 31 members, 28 of them are voting members. 16 of these 28 are from specialties that do predominantly E&M services. It's an expert panel. When you get on this panel, you're supposed to not be advocating for your specialty. And so here's the first question for you. Can charges for a procedure be set by your practice and by you as a clinician? Can you set your charges? And of course the answer is yes, you can set your charges, but you ain't gonna get paid based on that. Right? You can set it at $1 million, but you may get paid $10. So how are payments for E&M, for evaluation and management, and procedures, how is that determined? Well, first it's determined by the RUC, and then it's other processes after that. So the RUC composition is all of these specialties. And the RUC advisory committees come from all the specialty societies that are part of the AMA House of Delegates. And I should have said the RUC is part of American Medical Association. It's done by the AMA. So the advisory committees all assist in the development of RVUs and present their specialties recommendations in the RUC. And this is my part of being any part of the RUC. I'm an alternate to the advisor for the College of Cardiology. So these specialties are also involved with the RUC, and they have members of both the committee as well as of the advisory area. So Medicare implemented this back in '92. That's when we were basically saying this is what we're going to charge and that's what you got to pay us, back when we could do that. And largely through a grant to a group at Harvard, they did an extensive study and came up with these base codes that were the base, and then everything from that point is a building block relative value on the original base things from Dr. Shao and his group at Harvard. So standardized physician payments for services are determined by the resource cost. And actually only as I was preparing this talk did I realize that doctors' RVU are viewed as cost. And you'll see for good reason why that is. I guess it's good. Most public and private payers now, as you know, are some sort of percentage of Medicare. So we talk about we want to fight a single payer system, but we have a single payer system. It's a single payer CMS system with everybody else built around that system. So the cost of providing each service is divided into three components. Our work is one of the costs, the practice expense of doing that work, and then liability insurance as part of the cost. The way our part of it is determined is predominantly by time. and I'm going to talk about surveys. It also has to do with skill, mental effort, and judgment, and the stress of doing whatever it is that you're doing. More about that to follow. The practice expenses were initially just whatever we said that it cost, and they approved it, but then they started going to resource-based for that based on the CPT codes, or current procedural technology codes, terminology codes. And then in 2002, it became completely resource-based for the practice expense. Likewise, the professional liability was also now resource-based. So this is the components of a single RVS, or one value. It includes liability, practice expense, and physician work. Now, we all talk about professional and technical. Well, this is the technical, and this is the professional. How does it work? Well, this group gets together several times a year, meets in one big room. The panel is in the middle, and then all the advisors around it. There's a big table way over here with lots of people from the various societies that come and bring their pleadings. The cycle of all of this is closely timed to some various things. RUC meets 3 times a year. CPT meets 3 times a year. CMS, after all this, publishes the physician fee schedule for the year in the Federal Registry. That's toward the end of every year. And then the codes go into effect every January the 1st. They change every year, go into effect. So again, the cycle is basically starts with CPT editorial panels. So cardiology says we have this new device of measuring pressures in the pulmonary artery called MIPS. We need a code for that. That goes to the CPT panel. After that's done, then it's sent out to all societies and say, do you have any level of interest in this? And the GI doctors say, I don't have any interest in that. And the cardiologists say, I do. And the Society of Cardiac Angiography and Intervention says, we do. So they do a survey of their members at that point. That survey then goes back to the specialty societies, to their committees, and then they present it to the RUC. The RUC approves or disapproves or changes or whatever. That then goes to CMS, and that becomes our payment. So that's the yearly cycle of how we get paid for what we do. This is an example, just to show you. This is January of this year. We sat down, and this is actually not all of it. These are called tabs, and each one of these have someone representing each one of these tabs trying to get things done for their society, like closure of left atrial appendage with endocardial implant. That's a cardiology thing. We had to plead for an RVU for that particular thing. Payments are then calculated by multiplying combined cost by the conversion factor. Payments are adjusted also by the GIPSy, the geographic differences. So to calculate how much payment you're going to get for a particular procedure, you have to baseline know the RVU. You'd have to see through a table what your GIPSy is. Y'all know what I mean by the Cornhusker Compromise? That in 2010 when Obamacare came out, Nebraska was fighting it. It looks like it wasn't going to pass, and they gave Nebraska a specific, really good GIPSy, more than New York City, as a matter of fact. That was a compromise to get them to pass Obamacare. What? Right, there you go. Right. So then you take the conversion factor, which is figured annually, more or less by Congress, but mainly through CMS, and now there's a budget neutrality adjuster to that. So here it is. You take the total RVU, you multiply it by the conversion factor, which at least for this year is this, and then you add in that budget neutrality, and then you add in the 0.5% that they promised us through the new MACRA law, but the budget neutrality is 0.51% and the other is 5%, so you really get a slight loss as a result of all that, right? So do y'all feel like we have a birthmark here? So the survey instrument is exceedingly important. If you get a letter saying, please survey this thing, that is what will largely determine what you get paid. For example, for that left atrial appendage occlusion device I was mentioning, cardiology did a pretty good job. They had a fairly good many people that did the survey. They gave a fairly good range of how long it took. They gave a fairly good idea of how much stressful it was and how much physical work was involved. So we were able to go to the table and say, here's our median, here's our 25%, we think the RVU should be such and such. And the RUC agreed readily because the cardiologists had done a good job at their survey. So keep that in mind, and both yourselves and in your societies really emphasize that to everybody. And they do have a video recently put out that'll help you, help your members know how to do the surveys. So are we making any kind of impact, or are we just baying at the moon there? Well, for RUC recommendations, CMS has been accepting typically at least 90% of what the RUC recommends. And even if they turn something down, you have an appeal process. So it comes out to be more than 90% of what the doctors are recommending through the RUC, CMS approves. There are subcommittees. We won't go into that. These particular things are required recently because they feel like there are a lot of misvalued services. So if you have any of these particular things or any of these particular things, they're being reevaluated by the RUC right at the present time. So an idea of that is codes under review. There have been this many deleted, there have been this many decreased, so you see they are saving some money by this process, but we have managed to increase a few and reaffirm a fairly good many also. So my brain's full, and we'll stop at that.